The following podcast is part of a certified educational activity titled Advancing Immunotherapy, Revolutionizing Cervical Cancer Treatment. Access the entire activity and complete the post-test at peerview.com/YQP860. Downloadable slides and practice aids are also available.
Greetings and welcome. I'm so happy to be with you today. My name is Brad Monk. I'm a gynecologic oncologist at Florida Cancer Specialists and Research Institute, where I'm the medical director of late phase clinical trials. I'm also the vice president of the GOG Foundation and the director and founder of GOG Partners. I'm really excited to welcome you to this educational activity entitled Advancing Immunotherapy, Revolutionizing Cervical Cancer Treatment. And I'm very pleased and honored to be joined by my colleague, Keta LaRusso. Keta, say hello, introduce yourself, tell us about where you work.
Oh, Brad, thank you so much. I'm so happy to be here with you. I'm Keta LaRusso. I am a GYM oncologist. I'm working in Humanitas University in Milan, and I'm so happy to discuss with you what recent new, what you call revolution in cervical cancer treatment with immunotherapy and what this will represent for our patient.
And it's really exciting. So what I'd like to do is I'd like to augment, share, and equip. I'd like to augment your knowledge. I know augment means you already have some knowledge, but hopefully we can expand it and share with you some tips that Professor LaRusso and I have in individualizing the approaches and personal treatment as we see patients not only with locally advanced cervical cancer, but also recurrent disease. And then to equip you to take these skills, quite frankly, and to preach the cervical cancer gospel, as you will, and to play it forward. To pay it forward, to teach other people to do what you are able to do. So first of all, I acknowledge that cervical cancer is more common in underdeveloped countries. But the purpose of this slide is to show that not only is it more common in underdeveloped countries, but the stage of disease is different depending on where the patient lives. So in this little box on the left, North America, about 38% of the patients have locally advanced cervical cancer. These are lesions that are too large to be resected. And you could see if you slide over to the right in Africa, it's almost 88%. So cervical cancer is more common in underdeveloped countries and also presents in advanced stages. So we have had two epiphanies, one anti-angiogenic therapy and also immunotherapy. When I was a younger man, I would do colposcopy. I still do. And my professor said, look, Monk, that is angiogenesis out of control. That's how you tell that's a cancer. And immediately I said, well, why don't we hit that? Why don't we stop angiogenesis? And we can now do that with bevacizumab. And then as we saw, especially Dr. LaRusso saw, immune therapy impacting other solid tumors, well, it should work in cervical cancer, and it does. And that's what we want to share with you. So in my lifetime, I've seen 6 practice-changing phase 3 trials. The first was in 1999, where chemotherapy was added to radiation. And I don't call it radiosensitizing chemotherapy because not only does it improve local control, but it improves distant control. And then in 2009, on behalf of the GOG, I had an opportunity to present 204, which showed that in the systemic opportunity in persistent, recurrent, and metastatic disease, which we call first line, 4B, persistent or recurrent, that the chemotherapy backbone was and still is platinum and taxane. And then the anti-angiogenic was added in 2014, the first targeted therapy ever in a gynecologic malignancy, published in the New England Journal, and I want to give Professor Tewari his props. And then ultimately here came pembrolizumab, which was added to that regimen. And now we even have second-line active therapy. And you saw the publication on July 3rd in the New England Journal of 301. And certainly now we're going back to the beginning and curing more patients by integrating immune therapy in Keynote-18, which was approved by the FDA on January 12th. So we have 4 checkpoint inhibitors in the clinic, 2 PD-1s, 2 PD-L1s. The PD-L1s are not FDA approved. Cemiplimab technically is also not FDA approved, but used widely around the world, particularly in Japan and Europe. There are different antibodies, IgG1, IgG4, and the clinical trials that I'm going to highlight briefly are on the right. So this has been a great journey. The accelerated approval based on 77 patients in June of 2018 with a 14.3% response rate, and then the confirmation, an earlier line of therapy in Keynote 826, and now ultimately utilizing it with chemotherapy and radiation. So that's what we do in drug development. Later line approval, frequently accelerated approval or conditional approval, earlier line of therapy and combinations, and certainly other tumor types if it's novel. And you see that what we're doing with our antibody drug conjugates, where the first approval was in a GYN malignancy. And the EMA and the PMDA in Japan do have cemiplimab in the second line, and that happened almost 2 years ago. So if you look at really what we've done, we've had an improvement not only in survival, but overall response rate. Prior to the utilization of chemotherapy in 4B persistent or recurrent disease, the average sort of lifespan was 7 months. And then in 2009, we showed that platinum taxane could improve that to almost 13 months and the response rate of 29%. Definitely not enough, but a step forward that did two things. Number one, it's not chemotherapy resistant. And number two, we can do randomized phase 3 trials in this setting. And then bevacizumab inflated that to 48% and improved the survival by about 4 additional months. And then the transformation of immune therapy, adding pembrolizumab to chemotherapy with or without bevacizumab, according to 826, almost 29 months and a response rate of 69%. So 826 is now approved in many, many countries and many, many continents and is the global standard in the first line treatment, 4B persistent or recurrent. So these are patients who were treated with the chemotherapy backbone shown on 204. I'll talk to you about not every patient is appropriate for bevacizumab, so bevacizumab was elected, and they got pembrolizumab, and then ultimately in 6 cycles, and then maintenance bevacizumab and pembro or just pembro alone versus placebo, a very ambitious trial that we were uncertain if we could win, so we made PFS and OS and CPS greater than 1 and greater than 10 in all comers. So we had 6 endpoints. And the short answer is yes. Revolutionized the world, published in the New England Journal, and you see on the left the improvement in progression-free survival in all comer, but really it's about overall survival. It's about helping patients live longer and live better, and we've done that. There's actually an improvement in quality of life. It's one of the few studies that showed that patients are feeling better. And the reason they're feeling better is because the cancer is not killing them. Okay. So you can see here in the FDA approved population with the CPS greater than or equal to 1, you can see a hazard ratio of 0.60 and that very exciting outcome and difference with a 28.6 month at the median. Now the median is just 1 point. At any given point along the curve, you have a 40% greater chance of being alive. It's fantastic. And in some places around the world, it is approved in all comer, and 90% of the patients were PD-L1 positive. So it works in PFS, it impacts OS, and it also helps shrink tumors. Again, the 3 analytic subsets, which are CPS greater than or equal to 1, all comer in the middle, and greater than 10. The exciting thing here is that there's a plateau at 3 years. You know, the treatment is for 2 years, and a year later, now 3 years, patients have not progressed, and maybe they could even be cured. So again, not every patient was appropriate for bevacizumab. A subset of those did not get bevacizumab, 37%. And I only show this because you should use bevacizumab if you can, and you can see the difference on the right where bevacizumab was not used and versus on the left where bevacizumab was. And you can see the control arm was just better when bevacizumab used, which is what 240 showed. Okay. And that's important because in BEAT-CC with the PD-L1, okay, required bevacizumab, and really confirmed what we were seeing in Keynote 826 with an improvement in progression-free survival and overall survival. So if you weren't convinced with 826, you probably were. BCC adds useful information, not only in PFS and OS, but also in overall response rate and duration of response. Now, 826 and BCC are similar, but they're not the same. BCC was an ENGOT-led trial. We had the honor to participate in that. 826 was not a GOG trial. BCC was an investigator-initiated trial and required bevacizumab. Importantly, it did not include a placebo. 826 did, and importantly, 826 looked at biomarkers and not yet. BCC has not. But the eligibility was similar, and I think they are complementary. So we've really evolved. The past was 204, and our Japanese friends said you can use carboplatin and 3-hour paclitaxel, and then bevacizumab, but now in the first-line setting, it's immune therapy. So every patient in the first-line setting should, if they're checkpoint naive, in my opinion, get an immune therapy. So I'm so proud of what ENGOT and the GOG have done together. And so I think checkpoint inhibitors are well established. And again, it's a no-brainer. So I'm going to turn it over to Dr. LaRusso to now talk about some practical points and to talk about this case that she outlined. So take it away, Keta.
Brett, thank you so much. You tell us a history of success, what we have achieved for our patient in the last year, and you are in all the trial and you really move the needle for our patient. And now we are moving forward. We, as you said, moving back in a potentially curative setting, the setting of a locally advanced disease. This is a history of a 66-year-old woman that presented with the postmenopausal bleeding. She had her last pap test, unfortunately, more than 10 years ago. At the physical examination, it was evident that we had a problem in the cervix because there was a large cervical mass, and subsequently the imaging, MRI and PET-CT confirmed that there was a tumor arising in the cervix and it was already invaded the bladder. So according to the new FIGO classification, this was a stage 4A tumor. So this is a really locally advanced disease, stage 4 with the bladder invasion. And actually what we can offer to this patient for more than 25 years to this patient, we only have concurrent chemoradiation, but concurrent chemoradiation may be potentially curative in more than 70% of patients. For sure, there are different according to the stage, but it's a potentially high curative treatment for our patient, particularly the modern radiotherapy, the image-guided radiotherapy, which had greatly impacted in local control, and local control in cervical cancer means overall survival, and also modern radiotherapy greatly reduced toxicity. So, for this patient, do we need PD-L1 expression to guide the therapeutic decision? We will deal about that, but I can anticipate that with respect to what Brad has already said on the necessity to test the tumor according to PD-L1, to offer pembrolizumab either in combination with platinum paclitaxel plus or minus bevacizumab, or as a single agent in later line, in this situation we need pembrolizumab. When we move in the locally advanced setting, PD-L1 inhibitor does not seem to be predictive of the effect of pembro. On the top of modern radiotherapy, we decided to develop Keynote 818 trial. This is the first randomized phase 3 trial evaluating the role of pembro in combination with concurrent chemoradiation in high-risk locally advanced cervical cancer. We enrolled more than 1,000 patients with high-risk locally advanced disease. According to FIGO 2014, this patient has FIGO stage 1B2, 2B, and node positive, or FIGO stage 3 and 4, regardless lymphnodal status. These patients were treatment naive, new diagnosis, and were randomized 1-to-1 to receive standard concurrent chemoradiation plus brachytherapy, or concurrent chemoradiation plus brachytherapy plus pembrolizumab 200 mg every 3 weeks for 5 cycles, followed by pembrolizumab 400 mg every 6 weeks for 15 cycles. It's important to underline that this trial has 2 primary endpoints: progression-free and overall survival. KEYNOTE-18 enrolled a really high-risk population. More than 90% of patients have the PD-L1 positive tumor. About 30% of patients were Asian race. More than 55% of patients had stage 3 and 4A tumor. 85% of them have node positive tumor. But in terms of quality of radiotherapy, up to 90% of patients receive what we call modern and standard radiotherapy. I mean IMRT or VMAT, and more than 90% of patients receive the appropriate dose of radiotherapy. And in this context of modern and standard radiotherapy, the addition of pembrolizumab significantly increased progression-free survival in our patients. The median progression-free survival was not reached at the time of this data analysis. The other ratio is 0.70, suggesting 30% reduction in the risk of progression in patients treated with pembrolizumab. At 2 years, 57% of patients in the placebo arm and 67% of patients in the experimental arm were free of progression. Why this is so important? Because in cervical cancer, particularly in high-risk cervical cancer, 80% of recurrence occur within the first 2 or 3 years. 11% more patients free of progression at 2 years suggests that among these patients, some patients can be cured. Overall survival was the other primary endpoint of the trial. At the first data analysis, the first interim analysis, overall survival was not yet mature. We have only 42% information fracture of events. Still, a trend toward an increase in overall survival was reported. 80% of patients in the standard arm were alive at 2 years, with respect to 87% of patients in the experimental arm, with another ratio of 0.17, 73 deaths. At the time of this first interim analysis, the confidence interval crossed the unit, but very recently a press release anticipated that also overall survival was significantly increased in patients receiving placebo. When we look at the forest plot, which are by definition event-driven analysis, the benefit in patient stage 3 and 4 was larger than in patient 1 and 2B with the node positive. And when you look at this subgroup analysis, here the benefit in terms of reduction in the risk of progression is huge. The other ratio here is, I have to say, very significant, 0.59, with respect to 0.91 in FIGO stage 1B2, 2B. But again, remember, these are event-driven analysis. At the time of this analysis, only 25% of events has occurred in FIGO stage 1B2, 2B, and the trial was not for sure powered to detect the different benefit according to the stage. But regardless of all these considerations, FDA in January approved pembrolizumab in combination with concurrent chemoradiation only for patients with stage 3 and 4A according to FIGO 2014 classification. We pay particular attention to the toxicity. It was the first time that we combined immunotherapy with chemoradiation, and honestly, we were a little bit scared on the potential overlapping toxicity, but we were really reassured because on the top of modern radiotherapy that provide not so huge toxicity, the addition of pembrolizumab did not translate in an increase of any kind of toxicity. And in particular, we pay attention to diarrhea. Diarrhea could be a problem because it is an overlapping toxicity between radiotherapy, post-radiotherapy colitis, and immunotherapy, autoimmune colitis. So we pay particular attention to this aspect, but as you can see, no difference in diarrhea between the two treatment arms was reported. And this was very, very reassuring. But also I have to tell you, all the other toxicity were in line. Because potentially when we use immunotherapy, all the organs may present immune-related side effects. We can have dermatological toxicity, rash and pruritus that should be cured simply by topical steroids and antihistaminic. We can have gastrointestinal toxicity, either nausea, vomiting, or, as I told you, diarrhea. In this case, require supportive treatment like antidiarrheals, but in case of grade 2, also steroids and antiemetics. But we can have also endocrine toxicity. In Keynote 18, 20% of patients reported hypothyroidism or hyperthyroidism. But in this case, hormonal treatment is enough to control the symptoms, and very rare, at least in our gynecological cancer patient, pulmonary toxicity that require for sure steroid. It's very important for us as a clinician to deal and to start managing this new kind of toxicity, which are different from what we have seen until now with chemotherapy, but require a learning curve. It's important for us to know when we have to expect this toxicity. Usually, skin toxicity is the first to occur within the first month of treatment, then colitis between the second and third month of treatment, and then endocrinopathies, thyroiditis, and later on, the more tricky toxicity, I mean liver toxicity, pneumonitis, and the last, nephritis. All of this can be managed. We need to understand what is happening. We need to educate our patient to report the symptom. We need to manage this toxicity better in a multidisciplinary setting, because our colleagues may provide very important insight about the management of this toxicity. And yes, we are in a very exciting moment from cervical cancer. Brad anticipated how magic was the pathway of our patient in the setting of metastatic disease, but now we are moving in a potentially curative setting. Brad, you said a very important point. Pembrolizumab in combination with chemo helps our patient to live longer and live better. And this is amazing. But to live longer with cancer is not exactly as to be cured by cancer. And potentially, here, we can cure the patient. So let's see what will be the reaction of the authorities when we will present the final overall survival data, and let's see what will happen in Europe according to the indication. But we are very keen to offer pembro in combination with chemoradiation to all our patients. But Brett, you were the PI of another important, amazing trial, the first trial that tried to combine immunotherapy with chemoradiation. Your vision opened the way to what we did after. You use a different drug. We use pembrolizumab. You use another drug. The difference is we use a PD-1 inhibitor and you use a PD-L1 inhibitor. In your opinion, this play a role in cervical cancer?
Yeah, thank you. First of all, you're an inspirational speaker. I'm inspired every time that I listen to you. And not only am I inspired, but I'm further educated. And so I appreciate you augmenting, as I said, my knowledge. And thank you for what you're doing. And we continue to collaborate on other studies. And I appreciate your leadership, not only in Europe, but around the world. But you're right that I sort of mentioned there are two different anti-PD-1 therapies, PD-1 and PD-L1. And I'm not here to tell you that one is better than the other, but it is a controversy. And it's not just a controversy in GYN cancer, but it's relevant across multiple solid tumors. And the only way to figure it out is to randomize. We're not likely to do that. But the trial that you sort of highlighted called CALA was with durvalumab, adding to chemotherapy and radiation. There were subtle differences in the eligibility, but the time to the primary endpoint was very similar, including the follow-up, and the number of events was very similar. But A18 with pembrolizumab was positive, and CALA with durvalumab was negative. And you sort of see here on the left, CALA, nice try. And there was a separation, but just not quite enough. Okay. And the A18 separation was enough, not only to be statistically significant, but clinically relevant. And again, like I showed you, between BEAT-CC and KEYNOTE-826, there are differences. Same between A18 and CALA, there are differences and similarities. CALA was not collaborated with either NGOT or the GOG. I don't know what that means, but it's just the facts. But A18 was done with both groups. And I don't know if the GOG and NGOT, contributed to the success of A18. I would like to hope so. CALA, as I mentioned, there was some differences in eligibility. It was a little bit of a lower risk group. Sort of the easiest way to look at that is the number of aortic nodes. There are about 10% of positive aortic nodes in CALA and more than double that in A18. Again, those nodes were irradiated, but it sort of speaks to the stage of the patients. And I already mentioned that the events, 227 in CALA, 237 in KEYNOTE-18. There are plenty of recurrences in CALA to show a different 227. And the time maturity is very similar, median follow-up of 18.5 months in CALA and 17 months in 18. If you look at here, the comparison of PD-1, PD-L1, this time atezolizumab versus pembrolizumab, the control arms in survival are almost identical, 22.5 versus 22.8. That would sort of inform the risk of the patients. And now I'm comparing, 826 with Bev, but the differences are greater with pembrolizumab. A little bit greater at the median, 32.1, 37.6, but more importantly, 5% better in hazard ratio. And I sort of showed you that CALA and A18, there was a separation, but not enough. So I'd like to go back to Catherine's case. And so maybe you can continue your conversation and discussion, Keta, about your patient with high-risk locally advanced cervical cancer.
Well, thank you, Brett. Thank you so much. See, our patient, stage 4, so potentially eligible according to FDA indication. We test for PD-L1, PD-L1 was negative, but likely in the locally advanced setting, our subgroup analysis did not report difference according to the benefit of pembro with respect to CPS score. And also, I just want to remember that more than 90% of patients in KEYNOTE-18 were PD-L1 positive. So regardless of CPS score, this patient is eligible for receiving pembrolizumab in combination with chemoradiation and in maintenance for 15 cycles. So I think that this is really a great opportunity for this patient. We demonstrate that there is a significant increase in progression-free survival. We demonstrate that there is a significant increase in overall survival. You will see the magnitude of benefit in the coming months, but it is, I can anticipate, it is clinically relevant, and we demonstrate that this combination is safe. In all the trial, only one patient discontinued the whole treatment for an adverse event which was not related to pembrolizumab. So I can tell you that this was really, really safe and manageable combination. And we have to, when I have to decide, we have a drug that increases overall survival in the metastatic setting, and we have a drug that increases overall survival in locally advanced setting, which is a potentially curative setting. So the drug is variable. The decision for the clinician is where to put the drug. In my experience as clinician, and Brad, I would like to know what you think about that. But as clinician, as oncologist, GYM oncologist, we were educated to use the best drug we have as earlier as possible in the treatment algorithm where we can potentially cure our patient. So according to what will be the label and the reimbursement, I have no doubt that I will use pembrolizumab in combination with concurrent chemoradiation in my patient.
Yeah, it's interesting, and I've written about this. For the FDA to say to a patient, based on the indication statement, you're not sick enough, your cancer's not bad enough to justify the use of this important medication as you outlined. I can't imagine what that would feel like. That patient saying, my cancer's pretty bad, I'm going to get chemotherapy and radiation. It's too big to have a hysterectomy, but it's not bad enough. So I'm hoping, as you sort of share with us the overall survival, that there will become more confidence. It's interesting, and I talk to patients every day. When you tell a patient, your cancer is pretty serious, it might kill you, and we have a new FDA-approved medication that I think can help you. It comes with side effects, but it also comes with benefits. The good news is that the side effects are less and the benefits are more. She doesn't say, oh, let me think about it. She says, God bless you. She sometimes says, will my insurance pay for it? But it's a pretty simple discussion. So it's talking to patients fairly straightforward. And we tell them certainly more details, but they want to live. They want to get better. And it's a great honor to take care of them. So in conclusion, is this a medication available now in Europe with chemotherapy and radiation? I feel your enthusiasm, and it may be only in some countries. Give us an assessment of what is available with the A18 indication. I know it's not EMA approved, but is it available in some settings?
We ask the company to open an early access program to provide the drug to our patient. It's not yet open, but we are working on that.
God bless you. Well, this has been a lot of fun, and it really my pleasure. I got to say, it's fun to talk about the data that you created. It's not us. It's not us. You did it for your patients. And that has to feel good. I can tell you it felt good to discuss it with you. We've seen evidence that supports the use of immunotherapy for treating patients with cervical cancer. We've learned about effective approaches and how to integrate them both in the metastatic setting and in the front line. I'd like to remind you to download the practice aids associated with this educational activity as a resource for you, your staff, and your patients. So thanks again. We hope you found this activity informative and useful for your patients. And on behalf of Professor LaRusso, thank you and so long for now.
Thank you, Brad. Thank you for this fruitful discussion. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Merck Co, Incorporated. To access all materials for this activity, visit peerview.com/YQP860.